Okay, great. So welcome back to the MRCP Part 1 session. A lot of you are regular students from our regular course, and I see that we have some new students as well. So welcome, and I hope all of you are doing well and your exam preparation is also going well. So let's start with the preparation first. So let's start with a little bit about the preparation and how you're going to prepare for the exam. And then we'll start with the question. Then I'll tell you how to approach a question on the exam and how will you come up with the correct answer. Now, the session we're having today is about recalls. Now, the questions that you see on the internet and that are rotated around, that you see around, they're not the actual true questions that come on the exam because it's not allowed on the MRCP exam to come back and give in your questions, and candidates do not get any sample paper or anything of that sort. So the ideal tool that you can use to get an idea of the actual real exam is the test that is present on the RCP website. So please try to solve it before your exam to give you a very, very good idea about your preparation and also about the pattern of the exam. So always go on to the Royal College of Physicians website, and there's a sample paper there. It has about, I think, 120 questions, and try to solve it 15 to 20 days before your exam. So it would be really, really helpful for you. So all the recalls that we're discussing today are from the internet, from different sources. The candidates who come back and tell us about the high yield topics that were there on the exam. So I'll try to cover all of the high yield topics, so at least you have an idea that these are the topics you really need to polish and what exactly do you need to know when you're preparing for the exam. So let's begin. Let's discuss a little bit about pattern of the exam first for those who just joined us. So basically, the preparation time, if you're just starting your preparation, you should give at least 3 months up to a year of preparation. Once you decide that you need to give your MRCP Part 1 exam, keep a track about your daily working schedule. How many hours can you dedicate to your studying time? So if you're a full-time resident, if you're doing a very hectic residency in your home country, then it would be very difficult to study. So try to keep that in mind rather than just hastily trying to book the exam first and then preparing for the exam. So start your preparation well ahead in time, and then once you're confident about your preparation, you know your schedule, then book your exam. Then it also depends upon your background knowledge. If you're a current resident, if you're a fresh graduate, then your concepts, your core concepts would be really fresh. But if you are an older graduate or you're doing something else, working in any allied medical field, then you might not have the background knowledge for medicine, and you'll have to polish it up a bit before you book your exam. And then the clinical practice, if you're a medical resident or if you're doing your house job in your home country or your internship in your home country, then you would be encountering a lot of these clinical scenarios in your real time practice. So that would also really help you. But if you're not into clinical practice, if you're doing you're somewhere on the teaching side or you're doing any other thing, or if you're not practicing, then you would have to give some time to revise your basic core principles before you start preparing for your exam. Then the most frequently encountered question that we get all the time is about the question banks. Which question bank should you use? Which is the best one? So ideally, you should use any two question banks. You have a lot of different question banks. You have past medicine, you have past test, you have on examination, you have the med exam expert question bank. You can use any two. People ideally use past medicine first and then they use another second question bank. So that's the best way to do it. Then examination recalls. Please go through the recalls. Do not use them to rote learn any questions. Try to use them as a learning tool. So whenever you come across any question, like we'll just discuss it. So if whenever you come across any question, analyze, give it time, think about the question. Why is the option correct? Why is that option wrong? What is the additional information that the question is telling you or the explanations are telling you, so that you can keep a mental note about any new information that you come across. Then the last thing in your resources would be the notes. On the internet, you'll find numerous notes from different authors. You have Khalid Maghribi, you have Notes and Notes, you have the only notes, a number of notes that are available. But please be careful because these notes were written by authors at an earlier date. So if they're not the latest edition, you might not have the latest guidelines, and the guidelines keep on changing. And the candidates who are with us in our regular courses, they must be knowing that whenever we do our sessions, we do highlight whatever the new guidelines are, or if there are any changes in the guidelines. But your notes might not be that updated, so please be very careful while you're using them, because if the guidelines are old, then you might get those answers wrong on the exam. Okay. Then assessment. So assessment is very important. You should be aware of how well you're prepared for your exam, why before you book your exam and before you take your exam. So it would give you a really good confidence. It would give you a really it would really tell you about how what else do you need to do in order to improve your grades. So always try to solve mock exams. We have a very good mock exam on our website. You can do solve that mock exam very close to the real exam. And then you also have the Royal College of Physicians sample paper, which I just told you. So please make sure that you solve it, and solve it a few days before your exam, not on the day before your exam, because it would really freak you out if you get lesser scores. So give yourself time so that you solve it. See your mistakes. Where are you going wrong? What is your thought process, and why was it wrong? So give yourself a little bit of time to self-analyze your mistakes, and then time to polish if there's anything wrong going on there. Okay. Any question about the preparatory materials, the time regarding the preparation? I always tell my students to give yourself time before you book your exam. Sit down, analyze your schedule, your working schedule, your study time, and your preparation. I think you yourself know your background knowledge much better than I would be able to assess it. So always do a very honest self analysis before you book your exam. How to book the course? Okay, Dr. Yasmin, our course coordinators will just contact you. Okay. Okay. Now the examination pattern. So we have you will have a single day exam where you will have two papers. So you will have a 3 hour paper first, and then you will have a break for half an hour, and then you'll have another 3 hour paper. So both the exams are on the same day, and there are 100 questions in each paper. So that means you have 200 questions in each exam. Okay. Now, this is a rough analysis of the number of questions, and this is from the Royal College of Physicians website. So this gives you it gives you a suggestion, or it gives you an idea of how much you need to know. What are the average number of questions that you would be getting from each system? So cardiology, endocrinology, gastroenterology, infectious diseases, neurology, renal medicine, all of them have around 14 to 15 questions out of those 200 questions. And clinical sciences has 25 questions, and out of those 25, you have further subdivisions from biostatistics, anatomy, physiology. So while you're preparing for the exam, keep in mind that this would be the average number of questions. What happens is that sometimes candidates spend a lot of time on clinical statistics, maybe. And at the end of the day, you will have hardly 4 or 5 questions out of those. Not to say that you would not prepare for that, but keep in mind that you need to give extra time to the subjects where you will have a lot of questions. For example, in hematology, you have 10 questions. Then oncology and palliative care, again, you have 5 questions from oncology and 4 from palliative medicine. So you have approximately 18 questions out of those. So pay attention to that, that you might have to give more time to these subjects that are not, that we tend to overlook, but they appear more on the exam. Infectious diseases also, candidates tend to overlook that, but they do really turn up on the exam. If you're studying full time, Dr. Zahid, if you are not practicing, if you're studying around 10 to 12 hours per day, then you can prepare in 3 months time. But if you're giving 3 to 4, 5 to 6 hours per day, then you need to give at least 6 months to 8 months for preparation. And then at the end of the day, it would depend on how good your background knowledge is, how well you're able to retain all that information you're coming across. Okay. Okay. Now we will start with our questions. So I'll show you how you need to approach a question. How will you identify all of the important information on that question? And then once we get into the flow, then we will start solving it in a timed manner. Okay. Any questions so far regarding the preparation, regarding the things that we just discussed about the course content, the preparation, the exam schedule, anything of that sort? If that's clear, then we can just move ahead. Any questions? Okay. So this is an interactive session. I want all of you, 4-month dedication period, Dr. Khalid, would be enough, but at the same time, you would need to analyze yourself. You need to do a mock exam. You need to do self-assessments to see where you stand. Okay. So some candidates might study for a year and they might not pass. Some might study for 4 months and they could pass. But that would, at the end of the day, depend on how well you're prepared and how much information you're able to retain and how good are you at problem solving. Okay. I have to mute somebody. I can't see anybody who's unmute. Okay, I'll mute. Okay. Okay. Now let's start with the question. So this is the first question that we would be discussing. So I want all of you to read it, and then I'll show you how to extract all of the relevant information so that you can read the question, come up with the diagnosis, come up with the answer in 1 minute time, because you have 100 questions that you have to do in 3 hours. So you have around 1.5 minutes for each. So that's how you have to come read the question in such a way that you have to read the question in such a way that you do not have to read it again and again, and you're able to extract all the irrelevant information in the first read. So I want all of you to read it, and then I'll tell you how to extract all the relevant information. Okay, let me know when you're done. Okay, let's see some of your questions. Can we pass in last 15 days? Dr. Sky, I don't get your question. MRCP people can give MRCGP. In MRCGP, you have some more topics, like you have some ENT, you have ophthalmology, a little bit more detail. You have some, I think, pediatrics also. So that's the pattern is a little different. The medicine part would be the same, but you will have some additional subjects as well. Okay. Some obs and gynae, also a little bit of questions out of those as well. Okay, Dr. Yasmin. Let me know when you've read the question. Then I'll show you how to move ahead. Okay, the last 15 days of preparation would be more of revision. So it would be every day. If you're starting your studying, if you're giving it full-time studying, I would recommend solve at least one recall, and then see where you're making mistakes, and at the same time revise those topics from your notes or whatever question bank or your personal notes which you've made, and then start revising your past medicine or your question banks. Okay, revise as much as you can. So the last 15 days would be revision and your problem solving. So dedicate 3 or 4 hours to problem solving, question solving, and then the remaining for your revision. Okay. Okay. So you've read the question. Now, let's see what is the important information. Now, for example, the way I like to do it is, if you have a question paper and you have a pencil in your hand, once you've started reading the question, start underlining all of the relevant information in the first read. Okay. Don't read the whole question, then come back again to see what was the relevant information. Do active reading, be completely focused on the question, and start focusing on what the relevant information is. Okay. For example, you are reading the question. So the question was, there was a 67-year-old retired builder. So a 67-year-old is important. The age group is always very important because that would tell you if there's some congenital disease, something that's acquired, something that comes up in the earlier age, in the older age, or whatever it is. Then comes to the respiratory clinic. So respiratory clinic would literally narrow down a lot of your thinking process. You just start thinking about respiratory. Okay. And he's been diagnosed with asbestosis. Okay. So now you're thinking about occupational, and they're telling you that the patient has shortness of breath, he has decreased exercise tolerance, and he smokes 20 cigarettes per day. So very important information. So in just one read, you know that there's an old age man who's a builder who has asbestosis, and he's now presented with shortness of breath, and he's a smoker. Now you have on the examination, there are crackles which are consistent with pulmonary fibrosis, and there is some wheeze consistent with chronic obstructive pulmonary disease. So now that they're telling you that you have pulmonary fibrosis, you have COPD, the patient has asbestosis. Okay. Then when you're reading the investigations, once you're reading the investigations, always make a note whether it's normal investigation or is there some abnormality about it. So the hemoglobin is fine. Okay. The WBC count, the white cell count is okay, normal. The platelets are normal. The sodium is normal. Potassium is fine. The creatinine is fine. Now, so that once you start solving the question, you don't really need to go with this information again. You know that all of these lab parameters are normal. Okay. Now you start thinking on, now you come on to your next part, the x-ray. So you on x-ray, you have opacities and pleural plaques. Okay. And then on the CT, you have subpleural linear densities, you have lung parenchymal fibrosis, and you have peribronchiolar, interlobular septal fibrosis. So now you know that on the x-ray you have plaques and then you have fibrosis on the CT. Now, what does the question want you to know? So which of the following measures would be the most effective to slow down the progression of fibrosis? So what are they telling you? What are they asking you? Is there some problem with my voice? I don't know. I can't really appreciate any problem here on my end. Just a second. Is the voice clear now? Okay. Okay, so I'm waiting for all of you to answer so then we can see what the correct answer is. Very good. It's smoking cessation. They're telling you that the patient has COPD, the patient has asbestosis and fibrosis. So smoking will accelerate the progression of fibrosis. So, and it will also exacerbate the COPD. So if you ask the patient to stop smoking, that would be the best thing that you can do, and that would improve, that would stop the progression of fibrosis. Very good. Now, how will you use this exam recall question? Okay. Now, you come across a question of asbestosis. Now, what you have to do? You have to revise asbestosis. You have to take an overview of all the occupational lung diseases. Then you have to think about lung fibrosis, COPD, and smoking cessation. All of these are important topics. So maybe they could have asked you, instead of asbestosis, they could have asked you something regarding coal workers disease. Okay. Or they could have given you, in COP, they could have mentioned that the question could have been the same, and they could have asked you what would be the best modalities to see the prognosis in these patients. So what would have been the best grading criteria? What would have been the best scoring criteria to see the prognosis in these patients? What do you think? If the question would have asked you what would be the best way to see the prognosis in patients with COPD, a scoring criteria. Gold is the guideline. That's not the scoring criteria. No, the FEV one is not the FEV one is basically to see the severity. I'm asking about the prognosis. It's the board index. Okay. Okay. Where you see the BMI of the patient and you see the exercise tolerance and all of those things. Okay. I think you must have seen it in your question banks. You must have come across it. Okay. And then they could have asked you about smoking cessation. What are the different ways you can ask the patient to stop smoking? What are the different medications that you could use? Anything of that sort. So, whenever you come across any question regarding a particular topic, always keep in mind what are the different ways in which you could have been asked this question. The scenario, the vignette could have been the same, but the question stems could have been different. Okay. Okay. Now let's see the second one. Ideally, Dr. Aska, you should do two question banks. Okay, any two question banks. Okay, so what is the diagnosis? Rheumatoid arthritis. Very good, Dr. Anam. So yes, our diagnosis is rheumatoid arthritis, and the antibody would be IgM. So because our rheumatoid factor is basically the antibody, it's the IgM against the IgG. Okay. So how will you use this question whilst you are preparing for your exam? So once you've come across a question of rheumatoid arthritis, they're asking you the antibodies, they could have asked you the diagnostic criteria, or maybe they could have asked you what are the different clinical features or what are the respiratory complications of rheumatoid arthritis. They could have asked you about the diagnostic testing. For example, they just asked you about the antibody, they could have asked you about the role of CCPs, maybe, or they could have asked you what would have been the clinical finding on the x-ray of the hands, or what are the treatment options, or what are the side effects of those treatment options. Like if they are asking you about DMARDs, so they could have asked you what are different types of DMARDs, or maybe what is the side effect of methotrexate. So any of those, whenever you come across a question like that, always keep in mind to just skim through or revise your course content. Okay. So yes, Dr. Anam, you could have gone through the lecture also, but at the same time, if you do not have access to these lectures, then you can use the notes that you've made or your question bank, whichever you're using. Okay. Okay. Now let's come on to the third question. So let me know when you've done, and then we'll try to extract out all of the important information from this question. Done? Okay. Now let's see what is the important information in this clinical vignette. Okay. So here we have a 58-year-old man. So the age is very important. The gender is very important. Then it's the third admission. So that's important. That if it's a first admission, it's an emergency admission, or if it's some diagnosed disease. So that's very important. And the third admission with hepatic encephalopathy, despite taking regular medications, including propranolol and lactulose, and attending for surveillance, endoscopy, and variceal banding. So they're already telling you that this patient has CLD, decompensated CLD. And now let's see what they want you to know. So the examination reveals a blood pressure of 100 by 70. He has mild ascites and pitting edema. Okay, that's affecting both the ankles. Now let's see the laboratory investigations. So the hemoglobin, the patient is anemic. Okay. So just make a note of it. The white cell count is okay. It's normal. The platelets are low. Okay. The sodium is normal. Okay. The potassium is normal. The creatinine is fine. The ALT is raised, so you have a raised alanine aminotransferase and you have a raised alkaline phosphatase as well. So you see that all of the LFTs are deranged. You have low platelets and the patient also has anemia. Now, what do they want you to know? So, which is the best way to reduce the further future risk of encephalopathy in this patient? So, what would you like to add to their treatment regimen? Let's wait for the others to answer. Very good. So it's rifaximin. So rifaximin is basically the drug that is used to reduce the incidence of hepatic encephalopathy, and it's used whenever the patient has a hepatic encephalopathy in order to reduce the next episode. So we try to give them rifaximin. Very good. Now, what else do you need to know when you come across a question like this? You need to know what is the etiology of liver cirrhosis. For example, they could have given you a question like this and they could have asked you the etiology, maybe they, or they could have asked you anything regarding the clinical presentation, or any, maybe they could have just given you a scenario like that and they could have asked you the diagnosis, or maybe they could have asked you any of the complications. So, or for example, if they told you that the patient has ascites and the WBC count would have been raised, then you would have had to think about the possibility of SBP, okay, spontaneous bacterial peritonitis. So always keep in mind what are the different complications, what would be the treatment options. Or for example, they could have, instead of encephalopathy, they could have given you upper GI bleed. Okay, so always keep in mind what could be the different possibilities of questions. The concepts, the basic core concept, the diseases would remain the same. The way they would ask the questions would differ. Okay, so the way to use recalls would always be to always have thorough knowledge about any topic that you come across in the recalls. Always try to go through that topic from your books, your notes, or whatever you content that you're using. And that would really, really help you. Once you revise that topic in detail, the next time you come across any relevant or any similar question, you'll notice that you'll have a much better approach to that question. Okay, let's see the next one. Once you're done, let me know, then I can show you the important information in it. Done reading the question? Then I can show you the next part of it. Okay. Okay. Let's see what the question is telling us. So basically, you have a 65-year-old man. So again, an important point that this is an old age man, and you're reviewing him in the emergency department. So that's also relevant, important information, because your management and your the way you treat the patient would change if the patient is in an emergency or if the patient is in an inpatient ward setting. So you have to keep that in mind as well. And the admission is with a renal stone associated with left-sided renal colic. The stone was passed successfully, although an initial abdominal X-ray was negative and the stone was identified on an ultrasound scan. So basically, they're telling you that this was a radiolucent stone. So you could not see it on an X-ray, but you could diagnose it on an ultrasound. So this patient is obese. He suffers from hypertension and hyperlipidemia. And the medications that he's using include losartan, atorvastatin, and he's hypertensive as well. Okay. Now let's see the laboratory investigation. So hemoglobin is okay. The white cell count is normal. The platelets are normal. Sodium is all right. The potassium is also normal. The creatinine is mildly raised. Okay. The calcium is normal. And the uric acid is raised. Now you would almost kind of narrow down where you're thinking, your thought process would just narrow down to a few things. Now let's see what they want us to know. So, sorry, what would be the most appropriate intervention to prevent the formation of this particular kind of renal stone? So, what kind of renal stone was it? Yes, it was a uric acid stone. So, how would you prevent it? Very good. You would prevent it by using allopurinol. So, this is how you have to go through these questions to come up with a diagnosis. You have to think of a diagnosis and then you have to see what the question really wants you to know. Okay. Yes, if they would have, they could have asked you about calcium stone, they could have asked you about oxalate stones, they could have asked you about anything regarding that. They could have asked you why was it radiolucent, what are the different kinds of radiolucent stones, what are the different kinds of radiopaque stones, any of those things you could have been asked. Or how would you manage this patient in the emergency? How would you manage this patient? What kind of painkiller would you give? And then in the long term, how would you manage this patient? Any of those kind of questions. Okay. Okay, so we discussed that the patient is hyperuricemia and the renal stone was not visible on an X-ray and it was visible only on an ultrasound. So this was a urate stone. And so you have to advise the patient to take low purine diet. And then at the same time, you have to advise the patient to take allopurinol. Okay. Or instead of saying that the patient was hypertensive, they could have probably told you that the patient was on some chemotherapy or for some malignancy, or the patient was on any chemotherapeutic drug, so any or was suffering from some malignancy, so they could have also given you a scenario in that form. Okay. Okay. So what do you like to see when you see a question like this? You would like to see the different kinds of stones, different kinds of calculi. What are the risk factors of developing these calculi? What are the complications? How would you manage? And which are the drugs which promote the formation of stones and which are the drugs which prevent the formation of stones? Very, very important as far as the exam is concerned. They can give you about a patient, for example, there's a 75-year-old patient and the patient is has multiple comorbidities, maybe the patient is hypertensive, the patient is diabetic, the patient has 3 or 4 different comorbidities, and they can give you a list of drugs that the patient is taking thiazide, the patient is taking allopurinol, the patient is taking different kinds of drugs. For example, the patient taking ramipril, the patient is taking thiazide diuretics or whatever it drugs that promote the stone formation and which are the drugs which prevent the stone formation. Okay. So you can be asked the same thing in different ways. So you could have a question like that and you could be asked in different ways. Are you getting the point? Is the concept of using these recalls clear to everyone? Because memorizing the questions would not do any benefit to you. Instead, you would be making more mistakes, because if you think of those questions which are there on Facebook or which are there available on the internet, there are recalls. For example, I gave the exam and I came across a question, and what I remembered out of that question, I came back and I told you. So I might be not mentioning the complete information. I might have forgotten some part of the question, or I might have, my thought process could have been wrong. And you could, if you just memorize that part of the recall, so that would do more harm to you than doing benefit. Okay. So always use examination recalls as a learning tool rather than trying to memorize the questions and answers. Okay. Because a lot of times I get questions from candidates a few days before the exam that should we memorize these recalls, and the answer would be that um, that a lot of times candidate asks this question, that should we memorize these question and answers, and my answer would always be no. Never ever ever try to memorize these recalls. Okay. Okay, now let's see the next question. Let me know when you're done reading it. Okay. So you have another question where you have a 65-year-old man who has type 2 diabetes and he has hypertension and he's admitted to the emergency department with the sudden onset nausea, vomiting, and vertigo. Okay, so start narrowing down your thought process. What are you thinking about? Which system would you like to think about? So his blood pressure is 185 by 100 and the pulse is 95 and regular. He has left-sided Horner syndrome, okay, a reduced left-sided corneal reflex, paralysis of the soft palate on the left-hand side. He also has nystagmus, and there is loss of pain and temperature sensation affecting the trunk and limbs on the right. So he has a left-sided Horner's, and then he has weakness of the right side, and there's also loss of pain and temperature. Now just let's skim through the investigation. So hemoglobin is okay, WB cell count is normal, platelets are okay, sodium is fine, the potassium is okay, and what else is there? And the CT does not show any intracranial hemorrhage. Okay, now let's see what the question really wants us to know. Which artery is involved? Very good. It's the vertebral artery. Okay. It's the vertebral artery that has led to this syndrome where you have, which is the lateral medullary syndrome, and very clearly done because of the cerebellar artery. Somebody answered that as well. So you have disturbances of the vestibular system. So you had Gordon syndrome. You have, okay, let me mute everybody else. Just a second. Okay. Okay. So I was talking about the vertebral artery. So that would be leading to lateral medullary syndrome, and you will have involvement of the vestibular system. Now, what else could have been asked? They could have asked you what would have been the next step in the management of this patient. So, what would have been the next step in managing this patient? Would you lower down the blood pressure? Would you do TPA? Would you go for what would you go for? What would you do in the next step? Would you anticoagulate? What would you do? And they're telling you that it's a very acute onset of stroke. How will you manage? Before anticoagulation? Anticoagulation would have been the next step. What would you do in that window period? Yes, you would go for a TPA, but in this patient, would you go for a TPA? Yes, you would go for BP reduction. So, what would you like to do in this patient? How would you manage this patient? So, first, you would be reducing the blood pressure in this patient, and then you would go for TPA. Okay, this was the question. Okay. Very good. So, if you're preparing for your exam, always keep in mind the blood supply of the brain is very, very, very important, extremely important. The anatomy of the brain, neuroanatomy is very important. You should have an idea of what the different structures are and which part of the brain is supplied by which artery, which vessel. And if you get a stroke of any part of the brain, where would you find the lesion? Very, very important to know about the lesion and very important to know about the blood supply. Okay, so very important. You will have at least five questions regarding stroke on any exam in of MRCP that you come across. So they'll ask you a lot of things. They can ask you about the risk factors of stroke. They could ask you about the location, like I told you, about the blood vessels, the blood supply, and the areas involved. And the clinical manifestations are very important. They can ask you. They could have given you that this was the ischemia of the vertebral artery. Where would you see the lesion? They could ask you the lesion, and they could tell you they could ask you the blood supply, or they could tell you the blood supply and they could ask you the lesion. Then investigations, what would be the investigation that you would perform? The What would be the acute management, what would be the long term management, what would be the palliative care in these patients, and how would you control the risk factors in these patients? Hypertension, how would you anticoagulate these patients? So all of these things are very, very important. So once you come across any question of stroke, always have a look at all of these points that you could be asked out of any of these things when you're studying about stroke. So they can ask you any, if it's not necessary that they just ask you about the blood supply, they could ask you about the management, or they could ask you about the complication. Okay. Okay, now let's see the next question. Very good. All of you are correct. So basically, they're asking you that the patient is a Muslim, and you have to make some changes if the patient is fasting in Ramzan. So, what would be the main change that you would do? You would alter the schedule of of the metformin. You would be giving them 1 gram in the evening, because that's the main meal that the patient would be taking, a very high calorie meal that the patient would be taking. And then you would be giving them 500 milligram in the morning when the patient does their sahur. So that would be 500 milligram, and you would give 1 gram in the evening. Okay. So again, question on diabetes, but what else do you need to know in diabetes? You need to know about the pathophysiology of type 1 diabetes, of type 2 diabetes. You need to know the diagnostic criteria. What is the diagnostic criteria? How would you test these patients for, if you think that the patient is diabetic, how would you test? What is the fasting range? What is the random blood glucose ranges? What is the HbA1c range? When is it raised? When is it low? All of these things. Then inherited disorders are very important about Modi and LADA, both of them, the maturity onset diabetes of the young, or the late adult, the LADA syndrome that you have. So very, very important to know about these inherited disorders. What are the different mutations, and how would you manage these patients, especially the elderly population would avoid sulfonylureas. What would you, or if the patient has a deep creatinine clearance, then just a second. If the patient has a low creatinine clearance, and how would you adjust the doses if the patient is pregnant, if the patient has CKD, if the patient is in a fasting state? How would you manage all of these conditions? How would you arrange, how would you alter their drug regimens? Then diabetic ketoacidosis, very, very important. Again, there's a diagnostic criteria. How would you manage patients? How would you see the outcome of these patients? Very, very important. And complications, again, the microvascular complications, the macrovascular complications are extremely important. Retinopathy, nephropathy, neuropathy. You should know each and everything out of diabetes mellitus if you want to score really well on the exam. So whenever you come across any question in diabetes, keep in mind that it could not be just the drug regimen. You could have been asked about anything else also regarding diabetes. Okay. Clear so far? Any questions? Anything that is not understood? Anything that is not clear? Okay. Let's see the next question. Understood. Okay. Let's see the next one. Done. Okay. There are 45 participants and only 3 or 4 are answering. Please, I want everybody to participate. Nobody's judging you here. It's just for everybody's learning. Okay. So you have a question where you have a 28-year-old man. So very important to keep the age group in mind. And the patient is presented to the emergency department with central chest pain. So now just start thinking, brainstorming about all of the causes of chest pain in a young patient. Okay, which is worse on inspiration, which is relieved on setting forward. It already starts to bring your thought process. It starts to narrow down your thought process. Okay, he's been suffering from a flu-like illness which began a few days ago before the chest pain, and he's also suffering from intermittent fast palpitations. His blood pressure is 122 by 82, the pulse is 75, and regular, the chest is clear. Now let's see the investigations. The hemoglobin is normal, the white cell count is normal, the platelets are fine, sodium is okay, potassium, creatinine, and TROPS. All of the laboratory investigations are normal. Okay, now what do you think this is? What do you think the patient is suffering from? Yes, this is acute pericarditis. And what would you see on an ECG? What would you see on an ECG? Epsilon is not seen in, now see. What would you see? Yes, it would be the widespread saddle-shaped ST elevation in most leads, okay? See, you don't even need to know the entire question. You already know the information. So just now read the question carefully. Now read the question stem carefully. They've already mentioned ST elevation in the anterior leads, or is it saddle ST elevation in all the leads? Okay. Now be careful about your information. You know the answer, but while you're marking the question, while you're marking the answer, please read all the options carefully. Okay. Don't make a mistake in reading the question. Okay. And how will you manage these patients? What would you give to this patient? How would you manage it? How would you manage this patient? Yes, you would be giving these patients NSAIDs. Very good. So that's the initial intervention of choice. Okay. So yes, it would be symptomatic NSAIDs. Very good. So whenever you get a question like that, they could give you different diseases where you can have a specific ECG change. They could give you about HOCM, they could give about Wolff-Parkinson-White syndrome, pericarditis, any particular disease which has a very set, or Brugada syndrome, maybe a very set ECG pattern. They can ask you about MI, acute MI. What would be the finding on MI? What would be the blood supply? How would you manage different electrolyte abnormalities? They could tell you, they could ask you about ECG changes in hypokalemia, hyperkalemia, maybe in hypothermia. What would be the different ECG findings there? Then arrhythmias are very important about ventricular tachycardia, SVT, atrial fibrillation. All of these are very, very important. And how would you manage each condition? So if you have a patient with pericarditis, how would you manage that? If you have a patient with HOCM, how would you manage that? If you have a patient with Wolff-Parkinson-White disease, how would you manage that? If you have a patient with MI, how would you manage? If you have a patient with electrolyte abnormalities, how would you manage that? If you have a patient with atrial fibrillation, if you have a patient with VT, SVT, how would you manage that? So whenever you come across any disease, always keep a mental note of what it will it look like and how would you manage. Okay, clear? Clear to everyone? Okay, okay. The next one. So you have a 21-year-old man with cerebral palsy, and he comes to the emergency department with drowsiness, and that may be related to a urinary tract infection, and he's taking baclofen for muscle spasm. And how would you define the mode of action of baclofen? Okay. B, it's a GABA agonist. Okay. So it helps with the spasticity, it helps with the rigidity that the patient has. So it's used to improve the spasticity. Okay. So again, very important whenever you come across any particular drug, always think about the mode of action, especially the neurological diseases, the neurological drugs. If they're working on any autonomic receptors, so what are the receptor agonists, what are the receptor antagonists? The drug reactions are very important. So always keep a note of that. If you're not able to find all of them, you can find all of this information in first aid in the form of tables, so they're easily accessible there instead of trying to go through different books. You can use first aid for reference. Okay. Okay. So you have a 45-year-old man who presents to the emergency department with a wound in his left hand, and then which was sustained when he was separating his dog from another animal. And he had washed the hand soon after the injury, dressed it up to date, and you can see three clear puncture wounds. So sensations are normal. Which of the following is the most appropriate antibiotic intervention? So yes, it's a coamoxiclav. Um, that's the one that's given when you have a dog bite or any. And what is the organism that you would see in dog bites? Pasteurella. Very good. Pasteurella is the one that you see in Bartonella is in cats, Pasteurella is in dogs. So very, very important to know about different types of gram-positive or gram-negative organisms. What are be the antibiotics of choice? Then they could have also asked you about the vaccination status. What vaccine would you like to give to this patient? Which vaccine would you like to give, considering that this was a stray dog? Rabies vaccine, very good. How many doses would you give to this patient? Okay, very important to know about the different vaccines. Then special population groups, always, Dr. Anam, you can go through the rabies. Yes, there are three doses, 0, 0, 24, and 7 days, I think. I'll confirm them. And then what about the special population groups? Would you vaccinate in pregnancy? Would you vaccinate in, what would you do in a patient who has penicillin allergy? So very, very important to go through all of this information. Okay. Okay. The next question. Okay, so you have a 74-year-old woman who's taking fludarabine-based regimen for chronic lymphocytic leukemia, and she has to be transfused with irradiated blood. So why would you use that? Because irradiated blood would deplete the donor white cells, basically. So that would prevent the transfusion-associated graft versus host disease. Okay. So you can use irradiated units when the patient is immunocompromised, when they have some hematological disorders, if they have some intrauterine infections, so or if they have some congenital immunodeficiency. So all of these are conditions where you would be using irradiated blood. Okay. So what you need to know in this type of question, you need to know all of the hematological malignancies. They could have asked you maybe what is the mutation in CLL instead of asking about irradiated blood. Okay. Or they could have asked you about tumor lysis syndrome. Then what is the mutation in this um, malignancy, or what is the marker of prognosis, or what is the prognostic criteria, any of that. And about transfusion reactions are very, very important. Okay. Okay, so I just checked in the rabies vaccine. So if they tell you that the patient has already been immunized for rabies, then you only have to give them 2 doses. Okay. But if the patient has never been vaccinated for rabies, then you have to give them a full dose, which would be on 0, 3, 7, 14, and 28. So 5 doses then. Okay. So if the patient is vaccinated, then you only have to give them 2 doses. And if the patient is unvaccinated, then you have to give them 5 doses. Okay. Okay. The next question. Okay, so you have a 56-year-old female with long-standing rheumatoid arthritis, and she presents to the general practitioner with redness of the eye. She reports slight discomfort and being irritated with watering of the eye, and she denied any dryness and pain. So assessment was normal. And so what is the likely diagnosis? So somebody said keratoconjunctivitis sicca. So in keratoconjunctivitis, you would have dryness, okay? So the correct answer is episcleritis. Okay, very good. Those of you were correct. So scleritis is painful, episcleritis is not painful. So out of the many ocular manifestations of rheumatoid arthritis, the episcleritis is very common, and it causes irritation and soreness, but there's no pain as such. Okay. So very important to know what are the different ocular manifestations of rheumatoid arthritis. So you have keratoconjunctivitis sicca, very important, but there you would have dryness of the eye. They would tell you that the patient tells you that there's dryness. Then episcleritis, scleritis, you can have corneal ulceration, you can have keratitis. Then iatrogenic eye involvement is very important, because if you're giving the patient steroids, then they can develop cataracts due to those steroids. So they can tell you the patient is on steroids, and now the patient has started to develop a blurring of the vision, maybe. Sorry. Or the patient was taking chloroquine, and now she's developed she cannot see properly, or there's some blurring of the vision, and you notice that there is some retinopathy. So which is the drug that has led to this retinopathy? Then that's chloroquine, and it causes a permanent irreversible retinopathy. Okay. So very important to know about the basic manifestations of the disease itself, and then of the complications of the treatment. Okay. The next one. Acyclovir. Very good. So, if a patient is suffering from herpes zoster ophthalmicus, so that is the reactivation of the varicella zoster virus. Okay. So, all of you said acyclovir. That's correct. So, that's the reactivation of the herpes varicella zoster virus, and in the area which is supplied by the ophthalmic division of the trigeminal nerve. So you will have a vesicular rash, and then you can have a Hutchinson sign as well. So there's a rash on the tip of the nose, this one, this part. Okay. So always very important to know about what is the organism. So varicella zoster, they could have asked you about the treatment, they could have asked you about the complications of the disease, they could have asked you about the exact, which is the organism. So very important to know about that. Okay. Okay. The next question. Then let's see the next part of it. I'll show you the question again. So there's headache, retroorbital pain, and facial pain, and along with that you have ptosis and ophthalmos, and so there's a 1 day history. Okay. Very good. It's carotid artery dissection. Very good. So Horner syndrome and hydrosis, basically where you said the absence of sweating, that tells you where the lesion is. Okay. There was a question I think just went by. Somebody asked about sweating. So sweating would basically tell you where the lesion is. Okay. If there is absence of sweating everywhere, there's no sweating on the face, there's no sweating of the arms and the trunk, that means that there's a central lesion. Okay. Something related to the spinal cord, something related to the brain. So there would be a central lesion, it could be a stroke, it could be syringomyelia. But if it's just the anhydrosis of the face, that means that there is a preganglionic lesion. That means there's a pancreas tumor, there's a cervical rib, something to do with uh, a postganglionic phase. Okay. And if there's absent, then that means there's postganglionic lesion, which is the carotid artery. Basically, I'll just show you a table. Just a second. So if there's anhydrosis of the face, the arm, and the trunk, that means that there's a central involvement where that could be because of stroke, it could be syringomyelia, it could be multiple sclerosis, tumors, encephalitis, any of those. If there's only anhydrosis of the face, that means only the face is involved, that means that there's something related to the preganglion. Okay, so that could be because of pancreas tumor or thyroidectomy, trauma, maybe. And if there's no anhydrosis, that means that the sweating is completely normal. Then that could be because of either carotid artery dissection or carotid artery aneurysms or cluster headaches or cavernous sinus thrombosis. So here there was no anhydrosis. Okay. So that is why it was carotid artery dissection. So very, very important to remember this table. It would really help you to narrow down where the lesion is located. Okay. So if they would have told you that the patient has a 1 day history, but the patient has anhydrosis of the entire face, arm, and trunk, so that would have led you more towards stroke. Yes, no anhydrosis means normal sweating. Okay, anhydrosis means absence of sweating. So if there's no anhydrosis, that means it's normal sweating. Okay, okay. So you have a 22-year-old woman with sudden onset of loss of vision, and it was for 4 days, and it was associated with pain in eye movement, and the vision was severely impaired, and the visual field showed unilateral central scotomas. What is it? Yes, all of you are correct. It's optic neuritis. Very good. So a central scotoma is a feature of optic neuritis. So in this patient, the two most common symptoms of optic neuritis are basically visual loss and eye pain. And you could see all of this in demyelinating diseases or infectious diseases or inflammatory processes. So very important to know about these. Okay. So optic neuritis is very, very important topic as far as the exam is concerned. They could have asked you the diagnosis. What if the patient has had two or more episodes of as such? So that would have led they could have asked you, for example, the question was the same, and they would have asked you what would be the best step in the investigation or best step in the diagnosis of this patient. So MRI would have been the best, MRI of the brain and orbits with the gadolinium contrast would have been the best diagnostic option. Then how would you manage? Okay. Do you want me to repeat it again? Okay. So management, they could have given you the similar question and they could have asked you what would be the best step in the management of this patient, or what would be the best prognostic factor in this patient, any of that point. So if they ask you about optic neuritis, they can ask you about multiple sclerosis, they can ask you about diabetes, they can ask you about syphilis maybe, and a lot of different things can be asked from the same vignette. Okay. The last question, and then we'll take a 5-minute break. Today we'll be doing 100 questions, hopefully. Okay, so they're asking you the action of pilocarpine or pilocarpine. So it's basically a muscarinic receptor agonist. Okay, be very careful when you're marking agonist or antagonist. So it's a muscarinic receptor agonist. It increases the uveoscleral flow, and so very important to know which are the antagonist. Is my voice not audible? I don't know. Is the voice okay now? It's okay. Okay. So very important to know what are the different agonists, what are the different antagonists. So the muscarinic receptor agonist includes pilocarpine. The antagonist include atropine and hycosine. And then you have nicotinic receptor agonist, which includes nicotine and acetylcholine. Nicotinic receptor agonist, antagonist includes succinylcholine, atracurium, vicuronium. So very important to know about the different kind of receptor agonist and antagonist. Always have a list of those and try to go through them while you're preparing for your exam. Okay. Any question, any confusion so far, anything that is not clear? Anything regarding the different approaches of how to approach a question, basically. That's what I was trying to teach you today. Okay, so let's take a 5-minute break, freshen up, have a glass of water, and then we come back and then we'll start going through the questions at a little faster speed. Okay, no problem, Dr. Mo. You can work again. A lot of candidates do not clear it in the first attempt, but they can always clear it in the second one. And do not worry too much. Prepare while you're doing it, prepare it and then give it as early as possible. Okay. Okay. So we'll polish the different wherever you having problem. We'll just discuss it after the break. Okay. We'll see where you had problems. What were your score? So what was your score on the exam? Both the doctors who just told me. Okay, 492 is a good score, not bad. Very close to the passing score. So that means that you had 485 again. It was a good score, just a little bit of hard work, and hopefully you'll clear it in your second attempt. Okay. I think you might have had problem in memorizing or remembering the information that you had studied. Not, I don't think there was anything wrong with your preparation. I think because if you're getting a score which is very close to the passing score, that means your preparation was okay. Your preparation resources was fine, but you just have to work a little bit more on the exam taking skills. Okay. 469, anybody who has a score of 450 or above, I think they only need a little bit of more polishing, and they need to work a little more harder this time. And I'm sure all of you will clear your exam this time. Okay. Don't worry. Yes, I'll be more than happy to help all of you. Okay, let's take a 5 minute break. And when we come back, we'll see more questions. We'll see basic sciences also. We'll see all the different systems. Okay. Welcome back. So there was a question about the MRCGP. I think our coordinators would tell you in detail. They'll send you all of the information. Yes, our contact numbers and our WhatsApp numbers are being shared on the screen in our chat box. So you can both call them or contact them, and I'm sure they'll be able to help you in a lot more detail. Okay. Okay. Now let's do questions. And now I would be timing you on a 1 minute timer so that you can start practicing in the same way as you would like to do on the exam. So you will have a minute to read the question, solve the answer, and then we'll see where you are going right or where you're going wrong. Okay? Okay. So you have 1 minute. And I want all of you to participate, not just one or two doctors. I want everybody to participate. Um, Dr. Nafisa, Dr. Nida, I want all of you to answer. Whether it's right or wrong, no problem. Okay. So it's a case of a 12-year-old boy who's been brought by his mother and she has noted small yellow papular lesions and that his skin has become lax. And the GP makes a diagnosis of pseudoxanthoma elasticum. So, what is the ophthalmological finding that you would see? So, yes, the correct answer is the angioid retinal streaks. So that's the finding that you see. It's basically the mineralization of the elastic fibers in the Bursch membrane. So that leads to angioid streaks. So what are different diseases where you would see angioid streaks? So they're seen in pseudoxanthoma elasticum. You would be seeing them in Ehlers-Danlos, Paget's disease, sickle cell, acromegaly. All of these are conditions where you would be seeing angioid retinal streaks. Okay. I think this question was asked on the exam in August as well. From the feedback that we got to know about a question like that on the exam this time. Okay. Those who gave the exam in August, I think they can comment on that. Okay. The second question. Those who said Othello syndrome. Okay, let's see what the question is. So the question is about a 58-year-old woman who presents to the GP saying that her partner is not faithful. And she's very distressed by this. There's no evidence, but she's convinced. So what is this symptom of? So yes, this is a symptom of Othello syndrome. And it's a pathological jealousy where a person is convinced that their partner is cheating without any proof. So these syndromes are very important. They always turn up on the exam. They want you to know what is Othello syndrome, what is Charles Bonnet syndrome, what is Cabret syndrome. So it's the de Clermont syndrome, where there's a delusional belief that someone else is in love with the patient. So it could be any celebrity, it could be any famous person, and somebody whom they might even not know personally, and they have this pathological or delusional belief that that person is in love with them. Then there's a Charles Bonnet syndrome. Usually they ask you on the exam, there's a question on Charles Bonnet. It's basically complex visual hallucinations in patients who have partial or severe blindness. So the kind of question that you get on the exam is that patient has suffered a stroke and now the patient has visual disturbance, but they notice that there is some hat on the in the room, or the person is sitting in a room, or there's some hallucination regarding vision, and they themselves are blind or partially blind. So basically that's Charles Bonnet syndrome. And then there's Capgras delusion. Again, it's a delusion that a friend, spouse, parent, or partner has been replaced by an identical imposture. So they tell you that yes, this is my brother, this is supposed to be my mother, for example, but this is not my mother, this is an imposter. Okay. Then Cotard syndrome. Sorry. Okay. Then there's Cotard syndrome, that they themselves believe that they are dead or they do not exist, and that's associated with very severe depression. Then there is COVID syndrome. It's a sympathetic pregnancy in which the biological father suffers the symptoms of first and third trimester. Very bizarre kind of syndromes, but they usually ask on the exam. And then you have the Fergoli syndrome, Fergoli's delusion, where you have different people are in fact the same person in disguise. For example, they have a delusion that, for example, um, they have an enemy and they feel that everybody who's around them is the same person who's just disguised as that particular person. Okay. So these are the different types of syndromes, different types of delusions, and they're often asked on the exam. So please make a note of all of them, and you will definitely get a question or two out of these. Okay. Okay. Let's see the next question. Very good. You prescribing an SSRI for depression, and which class of drug is likely to interact with these? So it's a triptan which interacts with the SSRIs. So triptans should not be given to patients with SSRIs, and because they increase the risk of serotonin syndrome. Very good. So whenever you come across any drug, always keep a check on their drug interactions if they're indicated or contraindication. So so SSRIs are the first line treatment. Citalopram and fluoxetine are the ones that are more commonly preferred. Sertraline is the one that is used post myocardial infarction. I think there was a question on the group as well, and the reason why people were saying that's the answer is because of the post myocardial infarction. Then you have to be very careful for increased anxiety, increased agitation, because that's the complication, or that's the serotonin syndrome that happens when you're taking when you're taking an SSRI. Okay. And then citalopram and escitalopram are associated with QT prolongation, QT interval prolongation. So if they tell you that the patient has developed some cardiac complication, or the patient already has some cardiac complication, then you have to keep a check on the QT interval as well. Okay, the next question. I think this was also a part of this August attempt. I think so. So a man demands a CT. He states that he is obvious that he has cancer. And despite the previous negative investigation, this is an example of, so yes, this is an example of hypochondrial disorder. Very good. So in somatization, you have the symptoms, but in hypochondria, they believe that they have cancer. So always remember that in hypochondria, there is cancer, and in somatization, you have these symptoms. Okay. Okay. The next question. Again, a very important question, different kinds of question that you can get on the exam, where you have a patient who is taking a lot of medication for different comorbidities, and they can give you a side effect, and they can ask you which of the following is responsible for the symptom. Okay. So she's a woman who's 45 years old, and she has hyponatremia, and they want you to know which of these drugs is leading to the hyponatremia. So the drugs that she was taking included sertraline, she was taking carbimazole, she was taking amlodipine, metformin, aspirin. So yes, it's sertraline, and that leads to hyponatremia. Okay. So very important to see all of the other drugs that lead to hyponatremia. Don't need to remember all of them, but at least the important ones that are specific for any disease. For example, the SSRIs, the tricyclic antidepressants, lithium is important, haloperidol is important, desmopressin, all of these are the important drugs, carbamazepine, all of them which lead to hyponatremia. They're very important. Okay. Okay. Next one. So what is the patient suffering from? Very good, Dr. Smilin. She's suffering from PTSD. So there's emotional detachment. So that's the common feature of PTSD. Okay, post-traumatic stress disorder. So they have flashbacks, they have nightmares, and they're hyper arousal. That means they're very hyper vigilant. If you there's a noise around them or there's a sound around them, they get very hyper vigilant. They cannot sleep properly, and they're very detached, and they're very depressed. Okay. Okay. I think this was also in the exam this time. So, in which of them is not a feature of anorexia nervosa? There are no reduced growth hormone levels in anorexia. So, what is raised is the growth hormone, glucose, salivary glands, cortisol, cholesterol, carotenemia. All of these are raised in anorexia nervosa. Okay. So basically, the patient has a reduced body mass, they have enlarged salivary glands, and they have hypokalemia, low FSH, LH, but they have raised cholesterol and growth hormones. They have raised cholesterol, they have hyperkeratinemia. So try to remember all of these physiological abnormalities in anorexia nervosa. Usually you do get a question like that on the exam. Okay. Okay, another very, very important question. So you have a 65-year-old lady who presents to the clinic with a 6-month history of walking difficulties, and later on she has a recent history of urinary urgency. An examination reveals a short shuffling gait, bilateral postural upper limb tremor, extensor plantar response, and a 20 out of 30 on a mini mental state examination. What is the diagnosis? Very good. It's normal pressure hydrocephalus. You'll always get a question like that on the exam where they'll ask you about, they could have asked you about the diagnosis, or they could have asked you, what would you see on an MRI? So in MRI, you would see hydrocephalus with ventriculomegaly in the absence or out of proportion of sulcal enlargement. And they can also ask you about the treatment. How would you manage this patient? So you would be managing them with ventriculoperitoneal shunts. Okay. So whenever you get a question like that, so if it's about hydrocephalus, when you're going through a question like that, always brainstorm about the diagnosis, treatment, complications, all of these things. Okay. Okay. The next question. So you have a 73-year-old man with a history of falls, and now the patient has presented with confusions over the past 5 days. And on examination, the GCS is 14/15. She has nystagmus on the left lateral gaze. What is the most common diagnosis? So yes, it's subdural hemorrhage. So whenever they tell you about the fluctuating conscious levels, it's all, and history of recurrent falls, always keep in mind about subdural hemorrhage, especially in the older age population. Okay. So whenever you're thinking about subdural hemorrhages, always keep in mind what are the blood vessels that could have been involved. So which is the blood vessel that's involved in subdural hemorrhage? Which blood vessel is involved? No, it's not the middle meningeal artery. It's basically the bridging veins. Okay. Yes, it's the bridging veins. Okay, let's see the next question. Let me know when you've read the question. So whenever there's a question like this, always see the age group, always see the age group. What about what are the symptoms? So there's shuffling, then there's problem going up and down the stairs, then appears to be confused. So always keep in mind what are the different clinical signs and symptoms. Okay. Very good. It's progressive supranuclear palsy. Very good. So it's also known as the Steele-Richardson Olszewski syndrome. So it's also a Parkinson plus syndrome where you have postural instability and falls. There's a broad-based gait, and especially there's impairment of the vertical gaze. So down gaze is worse than the up gaze. So that means they have difficulty reading. They're going down the stairs. They can't see down properly. They can't look down properly. Then apart from that, they have bradykinesia, cognitive impairment, and frontal lobe dysfunction. So very, very important to know about Parkinson's, all of the Parkinson plus syndromes. Very, very important to know about that, okay? Okay. What has happened, Dr. Smileen? Why are you saying A? Why is it A? Yes, you cannot stop levodopa, carbidopa. You cannot discontinue. So you're right, Dr. Smileen. You would decrease the dose of carbidopa and levodopa because typical antipsychotics you have to avoid in patients with Parkinson's disease. And this basically what happens is that there's an increase in the dopamine because of the levodopa and carbidopa, and that increases the hallucination and the delusional thinking. Okay, very important. And you cannot stop carbidopa or levodopa because it causes the Parkinsonism, hyperpyrexia syndrome, which is similar to the neuroleptic malignant syndrome. So you cannot do that. Okay, so you have to just decrease the dose. You have to decrease the dopamine level, and that would improve the patient symptoms. Okay. Okay. Think about it, make a guess. So it's an approach to patient who's presented with to the memory clinic. He's coming forgetful. He has some kind of dementia. Neurological examination is okay. Blood tests are also fine. What would you like to do? How would you manage this patient? People who are saying A, why are they saying A? And those who are saying E, why are they saying E? Okay, so the correct answer is A. Basically, what you would like to do is you would like to rule out vascular dementia, maybe, because you would like to see and if there's anything going wrong, maybe, and that is leading to any reversible cause before you label a patient with as Alzheimer's or you're labeling them as dementia. You would like to see if there's subdural hematoma, maybe there's normal pressure hydrocephalus, any other etiology. First, you would like to rule that out. And once you've done that, then you would label them as Alzheimer's. Okay, clear? Everybody? Yes, after MRI. Okay. And assessment tools. Okay, a lot of times they ask you on the exam, how would you assess patients with Alzheimer's or how would you assess them for dementia? So basically, there are different scales that we use. The most commonly that we use is the mini mental state examination. That's the most commonly that we use. So if they have a score of 24 or less out of 30, that suggests dementia. I think this was asked in the August attempt as well, that they want you to know about. Which is a scale that is used for dementia or for Alzheimer's disease. Okay. Okay. Let's go on to the next question. So you have a 62-year-old female who's referred to dermatology due to a lesion on her shin. It started out as a small red papule, which later became deep red necrotic with a violaceous border. So what is the likely diagnosis? Yes, all of you are correct. It's pyoderma gangrenosum. So the lesions on the shin are very important. They want you to know what is erythema nodosum, what are the different diseases where you get erythema nodosum. Because if they tell you a patient has erythema nodosum, it would start narrowing down your differentials. So it's seen in sarcoidosis, you see in different infections like mycoplasma, maybe in inflammatory bowel disease. Some drugs can lead to erythema nodosum. Then you see pretibial myxedema with Graves' disease, pyoderma gangrenosum, and then in necrobiosis lipotica diabeticorum that you see in diabetics. Okay, so very important that you know the different kind of lesions which is seen on the shin. Okay, that really is asked on the exam every time. Okay, so a patient, 79-year-old female who was just diagnosed as being hypertensive, is taken to the emergency. She has recalls feeling giddy moments before, and she's just started a new medication. So, which medication did she start which led to this collapse? Very good, Dr. Nafisa and Dr. Zahid. Yes, it's Ramipril. Ramipril basically leads to the first dose hypotension, and that could lead to a syncope kind of an effect. Okay. So ACE inhibitors, they lead to first dose hypotension. Very good. I think this question was also there on the August attempt. So you have a 72-year-old man who's been diagnosed with prostate cancer and goserelin is prescribed. So which of the following is the most important to co-prescribe? So yes, it's cryptopyritone acetate. So what it does basically is that when once you start the um, gonadotropin analog like goserelin, what it does, it leads to a flare because of the because it's a steroid, it's a testosterone analog, it's a gonadotropin releasing hormone. So basically, what it does, it leads to a flare in the initial phases. So later on, once you give the cyproterone acetate, what it does, it just prevents that flare. Okay. Basically what happens is that gonadotropin releasing hormone is released in under physiological conditions, it's released in a peak, and then the level decreases, and then again there's a peak and the level decreases. Okay, there's a negative feedback mechanism, and that leads to um, the rise and fall of the gonadotropin releasing hormones. Okay, but once you start giving them to them iatrogenically, what happens there is that there's a persistent flare, a persistent rise in the gonadotropin releasing hormone. And since there's no negative feedback mechanism, it does not function. Okay, so that's the basic mechanism why we give them, why we give these patients gonadotropin releasing hormone analogs. Okay, so but what would happen is that in the first phase, where there would be the first spike of the gonadotropin releasing hormone, this is the time you want this to buffer, right? So in order to buffer the effect of these gonadotropin or gonadorelin analogs, you would be giving them cyproterone acetate, okay, which is the anti-androgen. Do you understand? Is this point clear, everybody, or you want me to repeat it?
Clear.
Okay, good. Okay, now let's go on to the next question. Very good. You have an 82-year-old man who's having vertigo and dizziness, and he has this feeling of his room spinning around. So basically, it's benign paroxysmal positional vertigo, very important as far as the exam is concerned. They want you to know how would you diagnose and how would you manage. So both of these things are very important. Okay. So it's the Epley's maneuver which is used, and the medication that is used. Both of them are very, very important. Okay. Okay. So you have a patient who has difficulty brushing her hair, she has difficulty standing up, and there's a purple heliotropic rash that telling you that the patient has dermatomyositis, and you start the treatment with steroids. But what else would you like to do? What else is the next important step, considering the different associations of dermatomyositis? Very good. You would like to do a malignancy screening test because dermatomyositis is usually associated with malignancy. So, associated with ovarian tumors, breast, lung, all of these. So, you have to always rule out um, the underlying malignancy in a person who is old age on a new onset of dermatomyositis. Okay. Okay. So you have a 26-year-old lady and she has a rash over her thorax and abdomen, and there are numerous teardrop cells. So where do you see teardrop cells? Teardrop lesions, in fact. What is the underlying pathology? Very good. It's gutate psoriasis. So what is the treatment? The treatment would be ultraviolet B phototherapy. Very good. So it's seen in adults, children, adolescents usually, and is precipitated by a streptococcal infection. And you have teardrops on the teardrop-like papules, and they have an acute onset and they tend to resolve within 2 to 3 months. But if you give them ultraviolet B phototherapy, that improves that just hastens the recovery. So very important to know about glutate psoriasis, very important to know about tyriasis rosacea, the difference between the two. Usually they asked on the exam, especially, just a second. They asked on the exam the pattern. So cutaneous psoriasis will have a teardrop-like pattern, but they tell you about fur tree appearance in psoriasis rosacea, and about the management options are also very important. So very important to know the difference between the two. So in so this is what cutaneous psoriasis looks like. So these are these teardrop kind of lesions. Okay. And Tyriasis rosacea, this is what it looks like. So it looks like a fir tree kind of an appearance, light pink colored rash, but it's just more widespread. Okay. Okay. Again, a very important concept as far as the exams are concerned. Drug reactions, drug side effects are very, very important. Whenever you come across any drug side effect that is very specific to that particular drug, always keep that in mind. Okay. So you have a 17-year-old male who started taking an antibiotic for acne, and he stopped taking the drug because of the alteration in his skin color. So there's some increased skin pigmentation, and that is because of minocycline. Okay, minocycline is the one that leads to irreversible skin pigmentation. Tetracyclines are more associated with photosensitivity, but the skin pigmentation is more because of minocycline. Okay. Okay. So the treatment options are very important. You need to know what are the different topical therapy that we can offer. You can offer them topical retinoids, benzoyl peroxide, and then in the oral ones, you can offer them oral antibiotics. So erythromycin is used in pregnancy usually. Minocycline now not used because of the possibility of irreversible skin pigmentation that we just discussed. Okay. Okay, and retinoids are obviously contraindicated in pregnancy and women who are planning to get pregnant, so we do not offer them retinoids. Okay, next question. Again, a very important concept. You'll always have a question on this kind of a question where they will give you a malignancy and they ask you the paraneoplastic syndrome, or they give you the paraneoplastic syndrome and they ask you for the malignancy. So which is the correct pairing? Very good. Erythema gyratum is associated with lymphoma. It's also seen with lung cancer. So it's a paraneoplastic eruption with wood grain pattern. So this is what it looks like. Okay. It looks like a bark of a tree. This is what it looks like. So very, very important to know about the different skin orders that are associated with malignancy. You will always, always, always get a question out of this. On every exam, every recall that you see, you will always have a question like this where they will tell you the paraneoplastic phenomena and they will ask you about the underlying malignancy. Okay, very, very important, especially about necrolytic migratory erythema, erythroderma, sweet syndrome. All of them are asked on the exam. Please be very careful, memorize them, and you will definitely get a question on the exam. Okay, another question. I think this was also on the exam this time. I've tried to include all of the concepts that were tested on this recent exam and the past couple of exams, so that none of the topics are missed out. And then while you're revising for your exam, you do not miss out on any topic. Very good. Yes, it's lichen planus. Uh, Always remember about polygonal violaceous papules uh, seen on the flexor aspect of the forearms. It's lichen planus. Okay. So they're plain, they're planar surface, they are purple, pruritic, and they are a polygonal rash. And always remember about the itchy white spots which are seen on the vulva of the elderly women, um, about Vicum stria, or very important to know about the oral involvement in the oral mucosa. They could have also mentioned that there's a whitish colored discoloration or white lace-like pattern which is seen on the oral cavity. Okay, very important. And how would you manage this patient? So it would be managed with the help of steroids. Okay, so this is what it looks like. Okay, so there is purplish, itchy, scaly rash. Okay, okay. Another question regarding the shins. Yes, it's pretibial myxedema. So they're telling you about an orange peel texture, very, very specific for pretibial myxedema. So this is what it looks like. So we have a shiny orange peel appearance. Okay. Sorry. So this is what an erythema nodosum looks like. So it's a very solid, roundish colored lesion, tender nodular lesion. Then you have the pyoderma gangrenosum, where you have this violaceous border. You have a necrotic border. And then you have necrobiosis lipotica diabeticorum, where you have this waxy kind of a lesion on the shins. Okay. So these are all the lesions that you remember. The picture is just there for you to memorize. So you can always think of what it looks like, because if you just look at the description, you might not be able to recall it. But once you've seen the picture, what it looks like, then you can always match the description with the picture in your head. Okay. You do not get any pictures on the MRCP part one. But if you just look at a picture, especially in the dermatology, you will always be able to remember what it looks like. Okay, and what it is associated with. Okay, another question. This was also from the August attempt. Those who've given the August attempt will agree. Very good. It's acne rosacea. There's always a question on acne rosacea. What precipitates it? What makes it worse? What improves it? There's always a question about acne rosacea. Okay, so please be very careful that it's alcohol which worsens it. And how do you treat it? How do you treat acne rosacea? Very good. It's metronidazole. We use metronidazole to treat it. Okay. This is what it looks like. This is what it looks like. The telangiectasias and the, okay. Topical metronidazole. Okay. Very good. Okay. The next one. So you have a patient who's 27-year-old and he has well-defined shiny erythematous patches in his armpits and groin. So this is, what's the diagnosis? What's the diagnosis? All of you are giving the correct answer, but nobody's telling me the diagnosis. Yes, it's psoriasis, flexural psoriasis. Very good. So how would you treat this patient? You would be using steroids. So first, you have to remember this entire regimen that is mentioned in your question banks as well. What is the first line treatment? How would you start the treatment? So you would start with corticosteroids and you would add a vitamin D analog. And how would you continue it? You would use it for 4 weeks. And in case it does not work, then you would increase the dose. You would increase the vitamin D analog twice. And then so on and so forth. You really need to memorize all of this regimen. Okay, very important. And which is the biological agent that you can use? It's infliximab, etanercept, adalimumab. All of them, you have to remember them because they usually ask on the exam. Okay. Then how would you manage scalp psoriasis, and how would you manage face and flexural and genital psoriasis? So you have to use a mild or moderate potency corticosteroids. To remember that, where would you use a high potency steroid and where would you use a mild or moderate? Because if you use it on the skin or on the exposed surface, it could lead to skin atrophy. So for skin, for the face, and for flexural and genital psoriasis, we use a mild or a moderate one because we do not want to get that part of the skin atrophied. Okay. Okay. The next question. Another very, very important topic as far as the exam is concerned. I think this was also there on the exam this time. Okay. Choose the question. Whenever you have a question where give you the pH and they're telling you the ions, the different ions, that means that you have to calculate the anion gap. Okay. Whenever they're telling you a pH, they've told you that the pH is acidic. Okay. And they're giving you the ions. They want you to know the anion gap. So what's the anion gap? What's the anion gap? Is it raised or is it normal? Yes, it's a raised anion gap. So when do you see a raised anion gap metabolic acidosis in out of these conditions? Very good. It would be methanol toxicity. Okay. So whenever you have a question like this, it means that you have to calculate the anion gap. Okay. Please be very careful. So it's methanol toxicity. Whenever they tell you about the eye involvement after a toxicity, um, that always means methanol toxicity. Okay. So Uh, so somebody answered ethylene glycol. Both of them present similarly, but the eye involvement is mostly seen with methanol toxicity. And when they tell you a raised anion gap metabolic acidosis, that means that this is methanol toxicity. Okay. And how would you manage these patients? You would use fomepizole. What is the mechanism of action of this drug? It's a competitive inhibitor of alcohol dehydrogenase, very, very important, or you can use ethanol as well. But what they want you to know is fomepizole and what is the mechanism of action. And then you can also use hemodialysis in these patients, okay? Very, very important concept about methanol toxicity. They always a question on the exam and they want you to know about it, okay? Very good. A very important association of metformin is that you should stop it in a patient who's had a myocardial infarction because it increases the risk of lactic acidosis. Okay, very important. And the second important thing that you have to see is the creatinine of the patient, because you have to reduce the dose of metformin if the patient has a decreased creatinine clearance. They usually tell you, if they give you, for example, you have a patient with multiple comorbidities and they tell you that the patient's creatinine is raised. I think there was a question on metformin also. I think there was one. I have, I'll show you the choices again, just a second. So they can give you a question with a patient having different comorbidities, which includes diabetes, and they tell you that the patient's creatinine is raised, or the patient has had a UTI which led to a rise in the creatinine. So what would you do to do the remaining treatment regimen? So you would decrease the metformin level. You would decrease the dose of metformin. Okay. If the patient's creatinine clearance has fallen to less than 45, you would half the dose. And if the patient's creatinine clearance is less than 30, then you would stop metformin altogether. Okay? Seen the question? Should I move ahead? Okay. So please be careful about the different side effects of metformin, about lactic acidosis, and about the creatinine clearance. Very, very important that you should reduce the dose of the creatinine of the GFR is less than 45, and you have to stop it if the GFR is less than 30. Okay, very, very important. Okay, okay. So another question where they want you to know what are the different indications of immunoglobulin therapy and where is it not used. So it's not used in thrombotic thrombocytopenic purpura. Okay, the remaining diseases where it's used in immune deficiencies, it's used in ITP, it's used in myasthenia gravis, it's used in GBS, it's used in Kawasaki disease, it's used in different kind of demyelinating polyradiculopathies. It's used for dermatomyositis. Okay, so it's the question that you need to remember. Okay, read the options carefully. Yes, Dr. Arvind, you're right. So doxazosin is an alpha 1 antagonist. Okay, it's not an alpha 1A antagonist. I'll show you the list of drugs. So the alpha 1 is doxazosin, alpha 1A is tamsulosin. Okay, always remember these. And alpha 2 is euhimbine, and the non-selective one is phenoxypenzamine. Okay. And the beta antagonists, the beta one is atenolol, and the non-selective ones are propanolol and carvedilol, and levodopa are mixed alpha and beta. So always remember these adrenoreceptor antagonists. You will always get a question on these few drugs. Okay. So always remember that alpha 1 is doxazosin and alpha 1A is tamsulosin. Okay. Okay. The next one. Read the question and I'll show you the option. So you have a patient who developed renal failure. So what would you stop immediately? So yes, it's ibuprofen. You would be stopping NSAIDs, and any patient who has acute kidney injury or chronic kidney injury, you have to stop that right away. So very, very commonly asked on the exam, which drugs should be avoided in renal failure, which drugs need dose adjustment. So the ones that you're supposed to stop altogether include tetracycline, nitrofurantoin, NSAIDs, lithium, metformin, all of them are to be avoided. And the drugs that you need to adjust the doses would be cephalosporins, vancomycin, gentamicin, and methotrexate, sulfonylureas. You all have to adjust the doses. But in renal failure, you have to stop all of these. Okay. And the ones which you can use safely would be erythromycin, rifampicin, diazepam, warfarin. You can use all of these. Okay. Okay, the next one. So 43-year woman is about to start treatment with trastuzumab for metastatic breast cancer. Which of the important investigation to perform prior to starting treatment? I think this was also on the August exam. Yes, it's echocardiogram because this drug is cardiotoxic. Okay, very good. So please be careful whenever you come across any side effect of any medication. Please keep it under check that it's used for what is directed against. It's directed against the HER2 new receptor, and it's used in metastatic breast cancer, and it can lead to cardiotoxicity. Okay. Okay. Very good. Yes, all the questions end up in pharma being that they ask you about the drug treatment options, or they ask you about the side effects maybe, or the mode of action, or anything of that sort. So pharmacology is interrelated to all of the other questions. Okay. Another question on drug interactions with lithium. So yes, it's ramipril. Very important association, always asked on the exam. They always ask you about lithium toxicity that is precipitated by ACE inhibitors. So what are the different, because it has a very narrow therapeutic index. So that is why you have to be very careful when you're using lithium. And it is used as a mood stabilizer in bipolar disorder, so very commonly used, but at the same time, it has a very high side effect profile just because it has a very narrow therapeutic index. So if the patient is dehydrated, if there's renal failure, if the patient is on diuretics, thiazide, ACE inhibitors, NSAIDs, all of them can lead to toxicity. Okay, very important to remember this. And when would you see what are the features of toxicity? So in toxicity, you would have a coarse tremor, okay? And if there's a fine tremor, that means that the patient's medication is in therapeutic level. So if they tell you that the patient initially had a fine tremor, but now has a coarse tremor, that means that earlier on the patient's dose was under therapeutic levels, but now it has become, now the patient has started to develop toxicity, okay? And how would you manage these patients? So mild to moderate toxicity would respond to volume resuscitation, while you would like to do hemodialysis in cases the patient has very severe toxicity. That means if the patient has developed confusion, or if the patient has developing seizures or coma, then you would like to do hemodialysis. Okay. Okay. Another very, very important concept as far as the exam is concerned, you will always get questions on this concept as well. So the patient was already taking warfarin, and now has taken some other drug which has led to an increase in his INR. That means what has this drug done? What has the second drug done? Has it increased the metabolism of warfarin, or has it inhibited the metabolism of warfarin? Yes, very good. It has inhibited the metabolism of warfarin. If you would increase the metabolism of warfarin, the INR would go down, okay? Because the level of warfarin would go down, the INR would go down. But if the metabolism is decreased, then the INR would go up, okay? The anticoagulant effect would go up and the patient would develop bleeding disorders, okay? So which of these following drugs would inhibit the metabolism of warfarin? So the answer is ciprofloxacin. Very good. Because ciprofloxacin is a P450 inhibitor, so it would lead to inhibition of that. Very important to know which are the inhibitors and which are the inducers of the P450 system. So very, very important. For example, if they would have given you rifampicin, that the patient was taking warfarin for something other disorder, but now the patient has developed tuberculosis and now you are giving the patient rifampicin, then what would you do? Then what changes would you do, make to the patient's warfarin dosage? What would you do? Yes, you would increase the dose of warfarin so that the effect would remain the same. Very good. So exactly this is what you need to remember, that if you're starting on a second drug, where if for example they tell you that the patient was taking warfarin, but now the patient developed seizures, so now you have to add um, sodium valproate to the patient's regimen, then what would you do to the patient's warfarin dosage? Or for example, the patient had a fungal infection and you have to add ketoconazole. So what would you do to the patient's warfarin dosage? You would decrease the dose. Very good. So very, very important to know which are the inducers, which are the inhibitors. You will always, always, always get questions like these, especially a ritonavir because used in HIV, isoniazid because used with for tuberculosis, antibiotics, very, very important. Then the all of the anti-epileptic drugs, they are inducers, but sodium valproate is an inhibitor. Okay, so very, very important to remember these inducers and inhibitors. Okay, next question. So which of these drugs are cleared by hemodialysis? Really? Tricyclic antidepressants are cleared by hemodialysis? Think again. Aspirin. Yes, you're correct, Dr. Smilin. It's aspirin. So the drugs which are cleared by hemodialysis, the mnemonic is BLAST. So the drugs include barbiturates, lithium, alcohol, salicylates, and theophyllenes. These are the 5 that are cleared by hemodialysis. Okay, very, very important to remember. Those which cannot be cleared by hemodialysis, they include tricyclines, benzodiazepines, then digoxin, beta blockers. They are not cleared by hemodialysis, okay? So the ones which are cleared, they are barbiturates, lithium, alcohol, salicylates, and theophylline. Okay. Okay, 49. Which medication have caused this photosensitive rash? A, Dr. Fahim, you're correct. It's amiodarone. Yes, amiodarone leads to photosensitivity. Okay. So the drugs which lead to photosensitivity include thiazides, tetracyclines, amiodarone. Amongst the NSAIDs, it's piroxicam, psoralins, sulfonylureas. All of them lead to drug-induced photosensitivity. Okay. Okay. 50th question, and then we take a 5-minute break. As far as biostatistics are concerned, just stick to the formulas. I don't think you will get very complex calculations because you're not allowed a calculator. So just stick to your basic formulas and just put in the formulas and you'll get an answer. Okay, don't worry too much about biostatistics. The biostat that is mentioned in past medicine or in our med exam question bank, I think that's more than enough. So whenever you have a data like this, always make a table. So you have positive, which is Down syndrome, and negative, which is not Down syndrome. Okay. And the test, which is positive, and the test, which is negative. Okay. Now, what is okay? I'll show you the set of data. Okay, so you had the test which showed positive in 15. So, for example, so this was your test which was positive, okay, and this was your test which was negative. So you had a blood test which was trialed in 1,000 women. Out of these, 20 were found to be positive, okay. So out of these, the new test which was positive in 5 out of the 20, 15 out of the 20 cases. So 15 were positive and 5 were negative, okay. And this test was also positive in 30 of the remaining 980 women. So you had 980 women here who were negative from your main test. But the new test that you used, you had 30 positive here, okay, who were tested negative, but according to the test, they were positive. And then you had 950 remaining here. Out of the 980, 30 were positive and 950 were negative. So yes, now you put in your formula of true positive divided by true positive plus false positive. Okay. So what is your correct answer? So this is your true positive, this is your false positive. Okay. So Dr. Chaudhary, you're correct. It's 15 divided by 45. So it would be 0.3. So you had true positives, 15 cases were true positives, and false positives were 30, who just tested positive on the test, but they were not actually Down syndrome. Okay. Got the point, Dr. Anam? You had no idea about it. Just put in the values in the correct order. Okay. Always just first, as soon as you get a set of information, make a table like this where you have the disease and no disease. Okay, so this could be any disease and this is no disease. Okay, then this is test positive and this is test negative. Okay, and then just put in the correct values at the correct places and you'll easily get the answer. Okay. Okay. So we've done 50 questions. Now we're left with 50 more. We'll just go through them. And after a break, let's take a 5-minute break. And then when we come back, then we'll continue with the remaining questions. Okay. Welcome back. So let's continue with the next set of questions. Okay. Very good, Dr. Smilin. Let's see what the others have to say. Now, I want all of you to be very fast because these are simple, straightforward questions. You know the answer or you don't know the answer, so that this shouldn't take you too much time. So very good. Yes, it's they are giving you a set of data and they want you to know what is the before and after exposure to a campaign, before and after treatment, before and after awareness session, any kind of a before and after data would be the Wilcoxon sign test. Very good. So very important to know what are different kinds of tests, when do you use each kind of test. So when is the Fisher's test used, where you want to see the significance of between two frequencies. The Pearson coefficient is where you want to see the correlation between two sets of data. And the regression analysis is where you want to see the whether there's this relationship between the dependent variable and another independent variable. Okay. Okay. The next one, a very important question usually asked on the exam. So if you have a data where you're doing where you're doing a study, where you're doing a randomized controlled trial, and there are a number of participants who drop out, then how would you analyze this data? Yes, very good. This is known as the intention to treat analysis. And whenever you have a randomized controlled trial where you have participants who drop out of the study, but when you do the analysis, you include everybody. You do not exclude them out. Okay. So this is known as the intention to treat analysis. Very good. Okay. Another question. I think this was also on the exam this time in the August attempt. So they want you to tell them what is the number needed to treat to prevent one patient death in from having further myocardial infarction. So what is the formula for number needed to treat? What is the formula? It's 1 divided by the absolute risk reduction. Okay. So what is the risk reduction here? What was the risk first and what was the risk later on? So what was the risk reduction here? So the risk reduction here was 1%, right? So what is 1% in decimals? It's 0.01. Okay. So 1 divided by 1 divided by 0.01 is 100. Dr. Smilin, you're right. It's 100. Okay. So the formula for this is 1 divided by the absolute risk reduction, which is the controlled event rate minus the experimental event rate. So it's 1 divided by 0.01, which is 100. Okay. Another important point as far as the exam is concerned, in our regular lectures, we discuss this in a lot of detail. Very good. So rheumatoid arthritis. So the HLA subtype, the genetic susceptibility locus is HLA-DRB1. Okay. So we discussed this in a lot of detail. What are the different types of HLA antigens and which are associated with which disease? So the A3 is with hemochromatosis, B51 is with Beckett's, B27 is with ankylosing spondylitis, reactive arthritis, HLA-DQ2, DQ8 is with celiac disease. Then DR2 is with narcolepsy and good pastures, very often asked on the exam. HLA-DR3 is with dermatitis herpetiformis, Sjogren's, and primary biliary cirrhosis. And HLA-DR4 is seen with type 1 diabetes and rheumatoid arthritis, and also DRB1. Okay. Okay, the next question. I think this was also on the exam this time. So you have a 42-year-old man who presents with intermittent dysphagia to solids and liquids, and there's regurgitation, and the barium swallow reveals a dilated, narrow esophageal body with distal esophagus terminating in a narrow end. So the patient is suffering from, what is the disease? Achalasia, very good. And the patient is suffering from achalasia, and the treatment would be you have to dilate with a balloon. The short-term management would be giving the patient nitrates or Botox toxins, but later on you would like to do some surgical management, and that would include dilation. Okay. So pharmacologically, earlier on, you would like to give the patient calcium channel blockers or botulism toxins, but later on you would use pneumatic dilatation or myomectomy. Okay, this is what it looks like on the barium swallow, where there you have dilatation and which ends in by narrowing of the lower esophagus. Okay, so this is the bird beak sign. Okay. The next question, another very, very important concept as far as the exam is concerned. Let's see what you people answer, and then we'll discuss it in a bit. The participants from our regular course, I think they all have seen these questions. They've solved these questions. We've done this in a lot of detail. And so the ones who are not a part of our regular course, I think they might be seeing it for the first time. Yes, Dr. Smilin, you're right. This patient is suffering from, what is the disease?
Wilson's, ma'am.
Wilson, very good. So it's Wilson's disease, and you will use for your diagnosis, you will be using the urinary copper level, and the urinary copper level will tell you if there is excessive copper excretion or not. Okay. So very important to know about the clinical features of celiac disease. What are the clinical findings in children? Because children usually present with liver disease. The young adults, they present with neurological disorders. And then the eye signs are very important. The other associations with renal tubular acidosis, hemolysis, all of these are very, very important. Now, the diagnosis is again very important. There are decreased ceruloplasmin levels, but the first investigation or the diagnostic investigation that you do would be the urinary copper level, and that would be increased. Okay. Then liver biopsy, if they ask you what is a gold standard investigation, then that would be liver biopsy, because that would be the most reliable investigation and would give you the amount of copper that has been deposited per gram of the liver substance. So that would give you a very accurate quantitative analysis of the copper deposition. Then how would you manage these patients? That would be with a low copper diet, penicillamine, triantine, and zinc salt. So all of these will be used. to manage these patients? Okay, the next one. So you have a patient with hematemesis and melena. Gastroscopy showed small esophageal varices that were not bleeding, and there was hemorrhagic gastropathy as well. So what would you use in these patients? So you would be using oral propanolol. Very good, Dr. Ian. So where you do not have any bleeding varices, there you would be using, and there is evidence of gastropathy, you would be using propanolol. Yes, because there are no bleeding varices. If there would have been bleeding varices or there would have been larger varices, then we could have gone for band ligation. Okay, they're telling you that they're very small esophageal varices that were not bleeding. If they would have been bleeding or they would have been large, then we would have banded them. Okay. Okay, the next one. Very good. So the patient is suffering from the patient is suffering from
Ulcerative colitis, ma'am.
oh, very good. It's the patient suffering from ulcerative colitis, and it's limited to the area of the sigmoid, I think. Yes. So the rectal biopsy, it's only limited to the rectum. So what would you use in that stance? So you would be using rectal mesalazine. Very good. Okay, the next one. So which of the following is a significant feature of hepatocellular carcinoma? Good. So the risk of hepatocellular carcinoma is increased in patients who have with hepatitis B who are E antigen positive because it's the marker of infectivity. So there's more activity, more viral replication going on, more hemolysis, more inflammation, more dysplasia, more chance of malignancy. Okay. Okay. The next question. I think this was also asked on the exam this time. So whenever you have a question on colorectal carcinoma, always see the pathophysiology, the different mutations, the familial mutations, very, very important as far as the exam is concerned. Okay, now a lot of people are saying depth of penetration, but the strongly in likelihood of metastasis. You're not asking you about the staging, okay? We're asking about the metastasis. So the metastasis, in which investigative finding? What would be the investigative finding that would tell you? So it would be the CEA levels, and that would tell you if there's metastasis or not, okay? That would tell you the recurrence also, and that would tell you the likelihood of metastasis as well. Okay, the next one. Very good. It's they're telling you that there's a female who's presented with um, ulcerative colitis, prolonged use of oral ketoconazole, and look at the age of the patient, okay? And biochemistry is telling you There's an ALT of 410, bilirubin of 260, and non-specific increase in globulin levels. The LFTs were normal 1 year earlier. So what is the correct answer? LKM1, I'll just show you the table if it's present. So they're telling you that 1 year earlier on, it was completely fine. Or what is the age group of autoimmune hepatitis? Is it in older age population or amongst the younger females? Younger. So what do you think? She's taking oral ketoconazole for 1 year. What do you think? Yes, it's drug induced. Okay. There is an LKM positivity, but the anti-LKM positivity is seen in younger children. If the patient would have been a young female or a young child who presented with, uh, yes, you saw LKM1, but see, look at the age group and look at the association. LKM1 is seen usually in children, okay, not in old age population. Okay, and they're telling you that the patient has been taking ketoconazole for a very long period of time. Okay, so please be careful. Okay, LKM again. Okay, so anti-LKM1 antibodies are seen in children. Okay, okay, Dr. Mo. Okay, the next question. Read the question carefully, all of you. You're making mistakes, silly mistakes. So, what is the patient suffering from? Polycystic kidney disease. So, what is the gene mutation in polycystic kidney disease? What is the gene mutation in polycystic kidney disease? It's polystin. Von Hippel-Lindau, they would have given you any history of seizures, any neurological association, any family history, something of that sort, okay? If they're only telling you about multiple cysts in the kidneys, yes, they would give you some other association as well. Retinal hematoma, lung malignancy, something else also associated with it. Okay? Okay, the next question. Von Hippel-Lindau has associations. Okay, it's not an isolated renal pathology. They would tell you that the patient has some other association, some neurological association, some family history, something of that sort. But if they're telling you isolated multiple cysts in the kidney, so that is more likely towards adult polycystic kidney disease. Okay. Okay. So you have, some are saying two, some are saying four. A 36-year-old man presents with history of red urine. This has occurred intermittently over the past 3 years. Okay, this is not continuous, this is intermittent. But he's otherwise well. His blood pressure is 160/95. Urine analysis shows +3 blood and +3 protein with red cell cast evident on microscopy. He excretes 1.6 grams of protein in 24 hours. What would the renal biopsy show? So somebody's having this on and off glomerulonephritis. So what is it? Yes, it's IgA nephropathy. Very good. So you would have mesenteroproliferative glomerulonephritis with IgA deposition. Okay. People who said C3, IgG, and IgM, I think you're thinking about the so mesangial-proliferative is the one with IgA deposition. If you're thinking about D, that's towards rapidly progressive glomerulonephritis. You will not get an intermittent, relapsing, remitting kind of a pattern. Okay. In membranoproliferative, in other kinds of glomerulonephritis, you will not get a relapsing, remitting pattern. You will have a continuous, progressive renal disease. Okay. Okay. The next one. So a patient with SLE has pedal edema, her plasma creatinine concentration is 101, but there's no hematuria. So what is it? Yes, it's class 5 lupus nephritis. So nephrotic syndrome without hematuria in a patient with SLE suggests membranous nephropathy class 5. Very important to know about the classification of lupus nephritis and the management of each. Very, very important, okay? As far as the exam is concerned. Okay, the next one. Very good. So you have a 23-year-old man who presents with shortness of breath, and then he has hematuria. At the same time, their fluffy pulmonary infiltrates and is negative. So yes, it points towards Goodpasture syndrome. Very, very important as far as the exam is concerned about Goodpasture syndrome. You'll always get a question on that about the management. You treat it with prednisolone and cyclophosphamide, and the clinical manifestations of Goodpastures. You'll always get a question on the exam. Okay, the next one. I think this was also on the exam this time. So the patient is having a peritoneal dialysis and now has presented with sepsis. So what is the underlying organism? The most common organism in this condition would be staph epidermis. Okay. So it's staph epidermis. And it makes up about 40 to 50% of the cases of peritoneal dialysis associated peritonitis. Okay. So what you need to do is you need to give them intraperitoneal antibiotics. So intraperitoneal vancomycin is usually given. And you have to remove the peritoneal dialysis catheter, and then you have to replace it with a new one. Okay. Okay, the next one. Very good. In patients with Crohn's disease, there are calcium oxalate stones that are most common. So there are calcium oxalate stones. Very good. Okay, the next one. Again, a very, very important topic as far as the exam is concerned. You will always get a question on this. Dr. Arvind, read the question again. The age group of the patient, the 72-year-old woman. Will a 72-year-old woman present with vaginas for the first time? Yes, very good. It's hemolytic uremic syndrome. So the patient is suffering from gastroenteritis. So it's basically an infection with E. coli. The variant is E. coli 157. So there's intravascular hemolysis, you have thrombocytopenia, renal failure. So very, very important um, clinical vignette that you get on the exams. And how would you treat them? You would be treating them with heparin, fresh frozen plasma, prostacyclins, and platelet inhibitors, but they do not have any major role. But at the same time, the antibiotics also do not have a main role, so you treat them with a plasma exchange usually. Okay, the next one. Nosebleeds, yeah, definitely, because all of the platelets are being consumed, so that could lead to nosebleeds. Okay, read the whole clinical vignette. Do not isolate nosebleeds. Okay, read it in context with the remaining things. Okay, so the patient has had heart failure, no, and there's evidence of hemolysis, thrombocytopenia. In vaginas, you will not get hemolysis or thrombocytopenia. Okay. Okay. The next one. Again, a very, very important topic as far as the exam is concerned. You'll always, always have a question on renal tubular acidosis. You should know the types. You should know which are the type 1, 2, 4, where is the lesion exactly, what are the different metabolic abnormalities, and what are the different associations. Yes, it's renal tubular acidosis type 4 because it's associated with hyperkalemia. Very, very important to know about renal tubular acidosis. You'll always have a question of that. Okay, the next one. I think this was also on the exam in the August attempt. Very good. So they're telling you that the female has a history of recurrent urinary tract infections as a child. So that is pointing towards reflux nephropathy. Okay. Very good. Okay. The next one. Very good. It's C6. The dermatomes are very important. Please go through these tables. I think they are also from past medicine only. Please go through the tables, the important dermatomes. Very, very important to know about the different nerve roots, especially the ones associated with reflexes. And the different nerve roots are very important, and the lesions and what would be the clinical manifestation of that lesion. Okay, very, very important to know those. Okay, the next question. Very good. So there's a young male who's presented with cardiac arrest, and there's a family history of sudden cardiac deaths, and the myocardial biopsy is telling you about fibrofatty infiltration. So yes, that's arrhythmogenic right ventricular cardiomyopathy. Okay, very often asked on the exam. Okay, the next one. Again, very important question. They always ask you about the different diuretics, and they ask you about where does it have its effect. So benfluorothiazide, so benfluorothiazide, so thiazide diuretics, they act on the distal convoluted tubule. Okay. So they inhibit the sodium chloride transporter in the distal convoluted tubule. Okay. The next one. Done? Very good. Yes, the patient is suffering from eosinophilic granulomatosis with polyangiitis, also known as Church-Ross. Very good. So the history of asthma, which is poorly controlled, eosinophilia, along with with the renal involvement. So yes, all of them point towards Church-Ross. Very good. So you have a female who's 23 years old and she was in diabetic ketoacidosis. Her pH is okay, but still she has positive ketones, which is the ketone that remains positive for a very long period of time. Very important to know about diabetic ketoacidosis. You will always have questions on diabetic ketoacidosis on the exam. So, waiting for the answers. So none of you were correct. So the correct answer is acetoacetate. Yes, Dr. K, you're correct. So acetoacetate is the one that remains positive for a longer period of time. The beta hydroxybutyrate is the first one that gets normalized, but the acetoacetate remains positive for a very longer period of time. See, the different compounds, they have different rates of metabolism. So beta hydroxybutyrate breaks down faster. Okay, that's why. So as soon as you give them insulin, they break down fast, they go back to their normal levels, but acetoacetate remain positive for a longer period of time. Okay. But beta hydroxybutyrate is the one that is the main causative agent why you get a positive ketone in your blood, in your urine or blood when a patient is in diabetic ketoacidosis. So that's the one that comes first, goes back first. But the acetoacetate remains positive for a longer period of time in lower quantities, lower amounts. Okay. Okay. Next one. Very good. And what is the malignancy that schistosomia causes? Schistosoma hematobium causes which malignancy? Which malignancy of the bladder specifically? Yes, very good, Dr. Smilin. It causes squamous cell carcinoma of the bladder. All of the other bladder malignancies are transitional cell, but schistosoma causes squamous cell carcinoma of the bladder. Very good, Dr. Nafisa and Dr. Smilin. Good job. Okay, the next one. Once you're done, let me know. I'll show you the labs. Okay. Very good. Yes, it's small cell carcinoma of the bronchus that leads to SIADH. That can lead to hyponatremia and all of this confusion and forgetfulness. Okay, very good. And how will you manage these patients? You would give them fluid restriction. Okay, next one. Very good. So yes, it's von Willebrand disease where you have bleeding tendency. It's an autosomal dominant pattern. Very important if they tell you that the mother and the daughter is suffering from the same disease. And what will you do to manage them? You would be giving them desmopressin, and it will help them before any surgery or any procedure, dental procedure, or anything that they take place. Okay, very good. Okay, the next one. Let me know once you've done it. Very good, Dr. Arvind, Dr. Anam. Good job. So whenever you have a question which tells you abnormal clotting profile, low platelets, raised D dimers, low fibrinogen levels, so all of them point towards DIC. So you'll always get questions on DIC. You would be getting questions on hemolytic uremic syndrome. You would be getting on thrombotic thrombocytopenic purpura. Questions like these will always be there on the exam. Okay, so please be very careful and know your concepts well. Okay. Very good. The patient has BRCA1 mutation, gene mutation. So what is the high risk malignancies? So yes, she would have a high risk of ovarian cancer. Good job. So they will have a high risk of breast cancer, ovarian cancers, very high risk. Okay. So what is the patient suffering from? Brugada. Very good. The patient is suffering from Brugada syndrome. So it's and which is the ion that is effective? What is the ion channel? What is the ion? Yes, it's the sodium channel. Very good. So it's the sodium channel that is affected, and that leads to sudden cardiac deaths. And the main ECG finding is ST elevations in lead V1, V2, V3. And it's the sodium channel that is affected, and you have to place an implantable cardioverter defibrillator. Good. So patient with myasthenia gravis is commenced on pyridostigmine. So what is the mode of action of pyridostigmine? Is it an cholinesterase inhibitor, or is it a muscarinic receptor antagonist? It's an acetylcholinesterase inhibitor. Okay, pyridostigmine is an acetylcholinesterase inhibitor. Okay, it inhibits the breaking down of acetylcholinesterase. So it inhibits the acetylcholinesterase. um, Acetylcholinesterase basically breaks down acetylcholine. So it inhibits the breaking down of acetylcholine. Okay, so it increases the effect. Okay, the next one. Very good, Dr. Smilin. You're right. Let's see what the other's thinking. Very good. It's the posterior cerebral artery stroke. So whenever you have a stroke on the right, so you will have homonymous hemianopia of the same side. Okay. So a posterior cerebral artery stroke leads to infarction of the visual cortex on the affected side. So, so you will have a left-sided, uh, that means you have a left posterior cerebral arteries affected. So that means you will have a right homonymous hemianopia. Okay, opposite side. Okay. I think this was also on the exam this time. Very good, Dr. Anam. Yes, it's depression. The patient has had a family history of there's a family death in the family, that the patient is there's apathy, the sleep disturbance. So that is the main diagnosis is depression. And how will you manage this patient? You will offer this patient cognitive behavioral therapy. Okay, the next question. Done? Very good, Dr. Harvin. Very good. So in patients who have heart failure with atrial fibrillation and who have an increased heart rate, then you would use ivabradine. Okay. So the indications for ivabradine are very, very important, that those who are not responding to treatment, those who have a heart rate above 75, and they do not respond to a beta blocker, then you would be giving them ivabradine. Okay. There's always a question on ivabradine on the exam. Again, a very important concept about different mechanism of actions of different drugs which are used at cardiology, neurology, very, very important. D. Yes, Dr. Smiline, you're correct. It's an adenosine uptake inhibitor. So basically, the dipyritamol it reduces the uptake of adenosine into the platelets. So therefore it increases the concentration of adenosine. So that it affects it's an antiplatelet. It inhibits the platelet aggregation. Okay. Please go through all of these drugs which are used in cardiology, all of these anticoagulants, all of the drugs which are used in angina, MI, all of these drugs, and please make a note of all of their mode of actions. Very, very important as far as the exam is concerned. Okay, clopidogrel, ticagrelor, all of these which are used in acute MI. Please make a list of these. Done. Very good. It's pseudo hypoparathyroidism, and in pseudo hypoparathyroidism, you have borderline calcium and phosphate, and they have the short fourth and fifth metacarpophalangeal joints, and memory impairment and okay, good. Again, the digoxin toxicity, very, very important. What is the sign? What is the ECG finding? What is the ECG finding in digoxin toxicity? What would you see in digoxin? If you're giving a patient digoxin, what would you see in an ECG? Very good, Dr. Arvind. It would be the reverse tick sign. Very good. Good job. So hypokalemia would lead to digoxin toxicity, and how would you correct it? How would you reverse it? You would correct the hypokalemia, and at the same time, the toxicity would get better. All of the other ECG findings would be there. The patient can develop long torsitis de quantis. They can develop other arrhythmias as well. They can develop all kinds of arrhythmias. But the main one that's characteristic of a person taking digoxin, that would be a reverse tick sign. Okay. Okay. Dr. Spillen, the patient can develop ventricular tachycardia, the patient can develop atrial fibrillation, ventricular fibrillation, all kinds of arrhythmias can develop as a result of digoxin toxicity. Okay. Very good. It's B. If the patient has hepatitis B surface antigen still positive, that means that the patient is still having infection. Now, it could be acute or it could be chronic. So, the acute or chronic depends on the IgM or IgG. I'll explain it in a bit. And for example, if the HBsAg is positive, okay, that means that there is infection. Okay, that could be acute or that could be chronic. Okay, now if the anti-HBs has developed, okay, that means the antibodies have developed. That means that this is resolved. If the hepatitis B surface antigen is positive, that means there is infection going on. There's hepatitis B infection is there. If the anti-Hep B C and IgM antibodies are negative, that means that this is a chronic infection. Okay, if this would have been IgM positive, that the core antibodies would have been positive, then this would have been acute hepatitis B reaction. Okay, hepatitis B infection. Or if the hepatitis B E antigen would have been present, that would have indicated all of the that would have indicated infectivity. Okay, so if the patient's hepatitis B surface antigen is positive and IgM antibodies are negative, that means that this is chronic hepatitis. Okay, clear, Dr. Anam? If this would have been previous hepatitis B, then the antibodies would have developed. Hepatitis B surface antibodies would have been positive. Okay, and hepatitis B surface antigen would have been negative. Okay. If this was acute hepatitis B, then you would have IgM antibodies positive. Okay. Okay. The next one. Very good, Dr. Arvind. So the characteristic feature of a reticulocyte is that it contains RNA. Very good. Okay, the next one. Very good, Dr. Smilin. Good job. Yes, it's chlamydia. It's reactive arthritis secondary to chlamydia. Okay. So basically, because of the unprotected intercourse, so that is leading to this reactive arthritis. So the treatment of choice would be NSAIDs. And if you have an underlying organism, then you can treat the underlying cause as well. So you have to treat the patient with doxycycline. And for the pains, for symptomatic relief, you will be offering them NSAIDs. Okay, the next part of it. Very good, Dr. Moore and Dr. Smilin. So eplerenone is basically an aldosterone receptor antagonist, and that functions at the distal portion of the distal tubule. Okay, good job. So it has almost similar function to spironolactone. Okay, okay, good, Dr. Anam. Very good. So hereditary hemorrhagic telangiectasias, it is autosomal dominant. Very, very important to know which are the diseases which are autosomal dominant, which are autosomal recessive, which are X-linked dominant, X-linked recessive. Very important to have a table of all of these diseases. Um, so very, very important. Okay. Very good. It's human papilloma virus. So that's associated with anal cancer. Good. The 16 and 18, both of them associated with anal cancers. Okay. So has a diagnosis of Lynch syndrome, which is hereditary non-polyposis colorectal CA, and he has two colonic adenomas, so which is the best step, next step. So the next step is aspirin. It has a protective effect. So aspirin has proven to reduce the risk of colorectal CA in patients with Lynch syndrome, and if it's given for more than 2 years. Okay. So specific different kind of information specific to Lynch syndrome. So always keep that in mind. Okay. Okay. No role of vitamins. Dr. Smilin. read carefully the question, especially or apart from the ulcers, the other clinical manifestation on the hands as well. Yes, it's Dr. Sindhu, very good. It's syphilis, it's secondary syphilis, because in secondary syphilis you have this rash. Okay, the macular rash is very specific to syphilis. Then you can have other manifestations as well. You can have cranial nerve palsies, meningitis, hepatitis, and later on they can develop cardiac complications as well. Management of syphilis is very important. They can ask you, how will you manage this patient? Okay, I'll show you the scenario just a second. So they can ask you the management of this patient. How will you manage? So you will give the patient single dose of penicillin, and they can also tell you that the patient is allergic to penicillin. Then what would you do? You would give azithromycin 2 gram as a single dose. Okay. So this was the question, Dr. Mo. No, no problem. I'll show you the question. Okay, let me know when you've read it. This is the rash. Okay. Okay. What is the pattern of inheritance of Fabry's disease? Since you're telling me this is an X-linked recessive, right? Okay. So he will be giving all the X chromosomes to his children. Okay. That means the sons will get the Y chromosome and the daughters will get the X chromosome. Okay. So this is the disease. Suppose this is the disease chromosome. Okay. So the sons will not get the disease. Okay. And the daughters would be carriers. Get the point? So what percentage of his children would be suffering? Zero. Very good, Dr. Nam. None of his children would actually be suffering. The daughters would all be carriers, but the sons would not have the disease. Okay. So none of his children would actually have the disease. So all of his daughters would be carriers. And later on, if the daughters have sons later on, then they would get the disease. But his immediate children will not have any disease. Okay. Okay. Very good, Dr. Arvind. Very good, Dr. Smilin, Dr. Anam. Yes, the beta 2 adrenergic receptors are located on the cell membrane. So, okay. Again, a very important concept as far as the exam is concerned. They'll ask you about pleural effusions. We discussed it in our previous lecture as well. So, very good. So, it's pH would be 7.1. So, pH lower than 7.2 is indicative towards rheumatoid arthritis. So all of the reasons why a patient would have a pH of less than 7.3 would be rheumatoid arthritis, it would be connective tissue diseases, malignancy, tuberculosis, esophageal rupture, all of them would lead to a low pH. Okay, the last question. I'll show you the labs again. Dr. Sindhu, look at the white cell count. Okay. Very good. Waldenstrom is the correct answer. Okay. Very good. Waldenstrom is the correct answer. The patient is old age male who's presenting with blurred vision. It's a B cell lymphoproliferative disorder. So these patients have headaches, blurred vision, and so basically peripheral neuropathy. There are no bone lesions. There's no renal dysfunction, but there's other hyperviscosity syndromes. Okay. Okay. With this, we end our session for today. I think you're welcome. I hope it was fruitful for you. You learned a lot. And please give us your feedback on to our representatives. That will really help us in improving ourselves as well. For any information regarding the exams, the courses, anything about the preparation, please contact the coordinators. They will also help you with your exam preparation. They can give you some feedback, individualized feedback according to your situation, because they're very experienced in doing that, and they'll help you with your preparation as well. And for our regular participants, on Tuesday, we would be doing our hematology in detail, and we would be revising all of the hematological concepts, the way we do it. And are there any questions from today's session? Anything that was not understood? Anything that was not clear? You're welcome. You're most welcome. Please keep in mind the way I taught you how to use your examination recalls. Do not try to memorize the question, because they're not the actual questions that came on the exam. They're all made up clinical vignettes by keeping all of the concepts in mind. So use these concepts, use the examination recalls, use your question banks as learning tools. So all the very best for your preparation. And if you have any questions or queries, you can always contact us. And see, if you're really keen on giving the exam, I tell you, a lot of candidates have this problem that they do not understand the exam pattern for the first time. If you're planning to give the exam for the second time, use all of that past trauma, use your past experience to help you score better. Sit down, take some time off, take a deep breath, make some self analysis. Where did you go wrong? Did you have less time to prepare? Or maybe you were too overwhelmed just before the exam, or you were too busy before the exam that you did not get enough time to revise. So all just sit down, make do a self assessment, see where you had mistakes, where you could have improved yourself, and then make a new planner, make a new plan, and then you can start studying again, and I'm sure you'll clear your exam. Okay, you're welcome. So if there are no questions or queries, we can end the session for tonight. So all the very best. Have a good weekend, and all the very best for your exams, and hopefully we'll see you soon. Okay. Thank you so much. Good night. The online exam, yes, there are I think 2 attempts per year for the online in UK. But I think you'll have to check the dates. I'm not sure what are the exact dates for the exam. So you'll have to check the RCP website. Okay. Okay. Good night. While practicing, I'm getting more questions wrong. I get depressed. Don't worry too much. First thing, make sure if are you tired when you start studying. Okay. And once you get a question wrong, do not fret too much. Use it as a learning tool. See where you went wrong and why did you go wrong. Is it your thinking process, or is it something to do with your recalling? Okay, are you having problems solving the answer, or are you having problem recalling the information? So if you're having problem recalling the information, then you should revise that topic or that system from your question banks. Or if you're having a problem in understanding the question, then you should practice question solving more. Okay. Okay. Dr. Arvind. You're welcome. All the very best. Take care and all the very best for your exam. Bye bye. Good night.